My name is Matt Blois. You're watching Medically Necessary, a show about the healthcare supply chain. I talk with experts, business leaders, researchers about how we get drugs, devices, and medical supplies to healthcare providers and patients. This show is brought to you by Ryder, the only fully integrated logistics and transportation provider in the industry. Ryder's solutions cover the entire supply chain, including warehousing, transportation logistics, e-commerce fulfillment, and last mile. Discover how Ryder can make you ever better at ryder.com. So today I'm talking with Rami Karjian, the CEO of Medically Home. The idea behind Medically Home is to help healthcare providers offer hospital-level care, but in patients' homes. So I think by now, probably a lot of viewers are used to talking to a doctor on Zoom for regular appointments that aren't, critical or things like that. But over the last couple of years, some hospitals have started trying to use this combination of telehealth tools and in-person care to provide more care for more critical patients at home, like hospital level care. And during the pandemic, even more hospitals decided to set up those kinds of programs. So I talked to Rami a couple of weeks ago, and he argues that really one of the things that makes these hospital home programs possible is just that it's the supply chain. Really, is what does it. Patients don't have these supply closets full of drugs and IV bags. So doctors have to know that the supply chain can deliver those materials on time and when patients need them. So we're going to be talking today about what the supply chain looks like for hospital home programs and, how the pandemic has changed the healthcare industry's perception of what those programs look like and what the future might hold. So thanks for joining me on the show. I guess, Rami, can you just start by giving us a little bit of background on hospital to home programs? What are they, and maybe a little bit of history, like when did we start seeing them appear?
Sure. Thank you. Thank you for having me. So hospital at home is not a new idea. In fact, if you think back to the early days of healthcare and the image of the physician coming to the home with the bag to treat patients in their home, that was the early days of hospital at home. It really started to take off in this country in the mid 90s, thanks to a researcher at Johns Hopkins, Bruce Leff, who worked with a team there to do a lot of research and pioneering hospital at home in the US. And then with the technology tools and the supply chain capabilities that improved over the decades since then, it's become a lot more sophisticated and available to a much broader audience. And so today's hospital at home, there are upwards of 135 hospitals in the US that are operating on hospital at home. Across the world, some countries like France have 10,000 patients at any time on census for hospital at home. And what we're really seeing is COVID, because of the capacity crunch that our hospitals here will put under and, vastly changing consumer attitudes towards hospitals, really magnified and accelerated hospital at home around the country. And most programs, including Medically Homes, we enable hospitals to provide this care to their patients. Most programs have, four core elements, as you can appreciate. They have a 24/7 command center where physicians and nurses telemedically provide the care. They have all of the equipment in the home that makes it feel to the patient that the physicians and nurses are there and vice versa, including all of the biometric monitoring and redundancy so that it's a medically hardened home. And then the critical aspect and one of the hardest parts of hospital at home is all of the logistics of the supplies, the services that, with FedEx-like reliability have to be there when the physician orders them, that sort of link the command center and the home. So you've got the command center, the home, the supply chain between them, and then typically a software platform that enables and coordinates all of that. Think of it as care traffic control, if you will, to make sure that all of those pieces are integrated.
I like the term care traffic control. That was a good one. And I like that you took it all the way back to, the old image of doctors doing house calls. It's, interesting to think about what the supply chain looked like back then and what it looks like now. And so I guess maybe talk a little bit more about, like I said before, we talked a few weeks ago, and I can't remember the exact quote that you gave me, but there was something you put it in a really good way about, what really makes this like the level of care that we can provide now possible in terms of hospital home is the supply chain. So like why is that the critical piece? Like why is that so important?
Yeah, so if you think about, a lot of the patients that are in our hospital at home model with our partners, a pneumonia patient, a COVID patient, a heart failure patient, the clinicians know how to treat that patient. It's very standardized. It's very well researched. The enabling part about hospital home is not how to care for the patients, but really the execution around that, creating the comfort for that physician that if they order the second round of IV antibiotics at 10 o'clock at night on a Sunday, then it's absolutely going to get to the patient. And that's one of the things that was holding back hospital at home was low acuity patients, the ones that really only need a couple of days in the hospital, they don't have very intense supply chain needs. And for a long time, some of the existing programs in the US were those low acuity patients. And what Medically Home did was really bring high acuity logistics, high acuity supply chain, high acuity technology available so that you could apply it for a much broader range of patients because of the reliability and capacity and coordination that it created. And that really changed, so many fundamental frameworks, probably in much the same way as, again, take FedEx, an example that's sort of obviously near and dear to the topic of the work that you do, Matt. The idea that I can reliably get a document across the country and across the world the next day changed the way we thought about doing business. In the same way, the ability to do high acuity hospital at home changed the way hospitals thought about being able to do care.
Yeah. Well, and I like that example of, you started off by saying, doctors know how to treat patients. Like we have the evidence of what works, what doesn't work. But I like that example of like, the doctor knows, okay, this is the action that I need to take. I need to give this antibiotic to this patient through this method, through an IV bag. And it's just the knowing that IV bag is going to get there when they need it. That's the tricky part. That's the part where supply chain really comes in. One of the things. Sorry, go ahead.
One other thing. And COVID was a great example of this. It really pressured the capacity and the resilience of our hospital systems. So when you get into a capacity crunch, it puts a lot of pressure on the physicians and the clinicians to get the patient out of the hospital to make room for the new patients, right? And so one of the things about this model for those high acuity patients, especially that the clinicians love, is you have more time. You don't have the pressures of, I've got to empty out that bed to take in the next patient. You also don't have the pressures of, hey, I have $1,500 of cost fixed cost per day of that bed. So, at some point with the reimbursement mechanisms, I've got to get this patient out of the hospital. In the home, with our high acuity model, the clinicians have more time to provide more care with more touches to the patient. And that's better for the patient to get that more care and more touches. And so the outcomes are better, including some studies have shown a reduction in mortality with hospital home versus traditional hospital. So more care over a longer period of time is better for the patient, better for the clinicians, better outcomes, and then also reduces the cost of the care because those outcomes are better. And so it's really sort of a win-win-win all around. But you have to be able to do it with high acuity patients. And the hard part is the reliability of the supply chain, because those high acuity patients, you have very, very little margin for error.
Right. Yeah, well, yeah, and I think that's an interesting way to think about it in terms of getting people out of the hospital. Because just from a patient experience perspective, I think me or anybody else who's seen loved ones in the hospital, like it's not a fun place to be. And so if you can get out there and be at home, I think that's really what patients prefer a lot of times. But if you're in that zone where it's like you really need pretty high level care, but you're almost ready to go, like this seems like a way to sort of get those, free up those beds for even more critical patients. And then those patients who are at home can still get the care they need. So like you're saying, there's not very much room for error when it comes to high acuity patients. So one thing I want to ask about, just like a detail thing, like where, if I'm at the hospital and the doctor says, okay, you need some antibiotics, let's go grab the IV bag. It's in, they've got it in their inventory in that same building. For a hospital home program, like where are the products coming from? Like where are they stored before they go to a patient's house?
And so this is where the data that we have can really enable safe care, because with the thousands of patients that our partners have cared for, we have data around which supplies are used by what type of patient on what day with what frequency. And so what we're able to do is when we admit a patient, they go from the emergency room to their home. When we admit them, we put in their home not only the technology, biometric monitoring, video and phone conferencing, redundancy, power, not only that technology, but we also put a supply box that's very carefully tuned to the supplies that the patient might need at a moment's notice, to make sure that you're not relying on, did the nurse bring the right type of test tubes with them? Did they bring the right type of catheter with them? And we know from the data what supplies are needed. The analogy that this group that's interested in logistics and supply chain will appreciate is, in the same way that Amazon knows on their trucks that I should stock USB cables, power chargers, before the order ever comes in, because I know the odds are pretty high that somebody today is going to want that USB cable. In the same way, we can do predictive analytics to know what supplies our patients are likely to need. And clinically, we know what supplies in a pinch, if you don't have them, are putting the patient at risk. And we put those in the patient's homes. And then we have logistics supply caches in several spots in the cities that we work in that we know we can get within a half hour from the supply cache into the patient's home. And then our hospital partners have everything in the hospital available to be able to get into the patient's home.
Okay, that makes sense. So it's like step one is sort of that supply box. You can say, this patient has X condition. We know we've got all the data to know if you've got this condition, you're gonna need syringes, you're gonna need IV bags, you're gonna need these drugs and these drugs in 2 weeks from now. Send those supplies that pretty sure that they're gonna need these. That's just sitting in the home. But then also you've got these sort of caches where if you need something else, you've got within 30 minutes places close by. And then the hospitals obviously themselves, you could go directly from the hospital, bring it to the patient's home.
Yeah, and when we designed the system, we had the chief pilot for air safety for American Airlines on our team. And so we thought about the redundancy that's required to keep high acuity patients safe in the way that an airline would think about them. So the supplies that you absolutely need in the home, then the nurse is going to come to the home, or the paramedic is going to come to the home with the supplies that you need. But as a backup, they're also in the home. And then we have the ability to courier them from the hospital or the supply chain cache into the home, just in case those first two levels fail. The way we think about technology, supplies, everything is multiple layers of redundancy, because again, with high acuity care, there's not a lot of margin for error. And with high acuity care in the home, the Murphy's Law is quite rampant, right? The number of things that we've seen, you just like, wow, that's a black swan event. The redundancy protects you against that.
Yeah, that totally makes sense. It's like you said, it can't, if you show up and it's like, oh shoot, we don't have the drugs here that I need. I'll just run back to the hospital. I'll be back in 2 hours with what you need. That might be too late. And so got to have the backup and the backup to the backup.
Exactly. And so you imagine you've got to be able to deal with the snowstorms, right, that are coming into Boston over the winter. And then you've got, the hurricanes in Florida. You've got the fires in California and Oregon, right? So all of that, it's the supply chain that allows you to medically harden the home due to the multiple layers of redundancy that need to be built in at all levels.
Yeah. Well, and it's interesting to think about, those three things you mentioned, like hurricanes, wildfires, winter storms. Obviously not something you'd have to consider if you're like bringing supply from one end of the building to the other end of the building. But those are all there, those are fairly predictable. Winter storms are going to happen in the winter, not in the summer. So I can imagine how you could use you could sort of make the redundancy smart in that way too. So you already started talking about this a little bit, but I'd be interested to know who gets the supplies from point A to point B. And it sounds like it's maybe a little bit different kind of depending on sort of the level of redundancy that we're talking about. But like who's doing the transportation there?
Yeah. And because of the redundancy, we really think about it as an ecosystem. And so the answer is always going to be there's multiple ways. But what we found very, very effective is paramedics, community paramedics that are trained for high acuity care that are going into the home with a lot of the supplies. That's very, very effective. And so we have a kit that every paramedic and every nurse carry with them that, we have our data analytics on what they need to have and clinically what do you have with them. But we also make liberal use of couriers, and we make liberal use of DME companies that can supplement. So it's really when the power of having an ecosystem in the way we think about the supply chain, having the backup to the backup means there's always multiple ways of getting something to the patient, which is part of what makes it so resilient, right? That you're not just reliant on, one method of being able to do it. If somebody's car breaks down, there are independent, redundant ways of getting, and by the way, that's happened, right? And so that's very important. And it's the ecosystem. We put nearly 40 different providers in any given city where we're operating the hospital at home, so that you have the ecosystem and you have the redundancy. And so you're never short of the capacity that you need to meet the needs of those high acuity patients.
Yeah. Well, and it's interesting because it sounded like, this is a little bit getting into the details, but, like you said at the beginning, you guys are providing a service to like a healthcare provider, to a hospital that's really running the hospital to home program. So who employs the people that are like bringing these supplies? Is it you guys? Is it the hospital? It sounds like maybe there's some independent contractor stuff. It sounded like, you mentioned like durable medical equipment companies, things like that. So who do they work for ultimately, I guess, is the question.
Yeah, and the fundamental piece is we really believe that only healthcare systems and healthcare providers are going to transform healthcare and take it to the next level. So all of this ecosystem orbits around the healthcare system, the providers that are providing the care with their doctors, with their relationship to the patient, and everybody needs to enable that. So the supply chain ecosystem that orbits around them and the patient is a combination of sometimes that health system has their own home health nurses, and we train them, we equip them with the tools that they need to go from home health to high acuity hospital care. And then in the community, there are existing companies like paramedic companies, like oxygen delivery companies that we tune, give them the tools, the workflows for high acuity care. And so it's rarely medically home's own employees. What we want to do is find existing resources within the community that are working well, give them the workflows, the tools, and the capabilities and the training that they need to go from home health to high acuity care, because that's what's going to scale most easily, as opposed to trying to bypass all that and create a new system.
Yeah, that totally makes sense. And it reminds me of, I just had a conversation, just wrote a story a couple of days ago about the supply chain for humanitarian aid. And one of the things that they mentioned was saying, we're an NGO, but really what we do is we look for like, what are the existing channels in the healthcare supply chain, and how can we sort of piggyback on top of that to make, to accomplish our goals. And it sounds like you're saying a little bit of the same thing. Like, there's existing things out there that work pretty good. Whether it's home health aides that are part of the health system, or whether it's, paramedics that are already there, and you guys, that sort of, it's easy to plug in and make that all work. Yeah. So we've only got a couple minutes left here. I find this all super interesting. And so I have a million questions for you, but I think I want to jump down to, sort of how the pandemic affected the way the healthcare industry views this type of program. Like, because I know there were some regulatory changes that happened over the last year. So how do you think How do you think the healthcare industry's perception changed when it comes to hospital home programs because of the pandemic?
Matt, I think it's really three things. Number one, to your point, a dramatically different regulatory structure. But that was really to support thing two, which was a different way of viewing capacity. And then thing three was resiliency. So let's start with capacity. What became very clear is we need a healthcare system that is able to flex capacity as we need it to deal with whether it's a pandemic, it's a natural disaster, it's big sort of large scale catastrophic accidents. And so the mentality around hospital at home, and particularly high acuity hospital at home, in its ability to create 20 to 30% more capacity, and a capacity that you can flex up and down and you can move around geographically is huge. And in fact, one of the things hospital at home showed is the clinicians don't have to be physically co-located or geographically proximate to the patients. So Mayo, as an example, their hospital at home program that we partner with them on, they have a command center in Jacksonville with physicians and nurses in that command center treating patients in rural Wisconsin. And so that capacity that you can tap for Wisconsin out of Florida is huge. And it relates to the third point, which is then resiliency. Now I can have more resiliency, more ability to deal with shocks to the system because I can spool up capacity and the capacity doesn't have to be co-located. And then the regulatory change that you described, which is support from CMS to this, is enabling now hospitals to get reimbursed for that care using the hospital at home model, allowing them to create more capacity, and importantly, especially for high acuity, more resilient capacity to cope with the next fire, the next pandemic. And because it's not centralized, just imagine when you have a fire in California, if your hospital is in the path of that fire, it's impacting 100% of your patients. With a hospital at home model, it's only impacting the patients whose homes are in the path of that fire. And now you can use hotel rooms, churches, other locations as a backup for more resiliency for that capacity. Whereas in a traditional hospital, the only place you can take patients if you're evacuated in the hospital is another hospital.
Right. Yeah, I think that's a super interesting way to think about it in terms of, sort of resiliency and preparedness. So we're coming up on the end of our time here, but so Rami, I don't think I have any other questions for you. Well, I do. I have a million other questions for you, but I think we're going to wrap it up right here. This has been a super interesting conversation for me. I love talking to you. I think you guys have a really interesting sort of concept here. So I hope the viewers got a lot of insights out of this as well. This is Medically Necessary. Thanks for joining us. You can catch us next time on Thursdays.
Thanks again to our sponsor, Ryder, for making this show possible. The coronavirus pandemic has changed many aspects of the healthcare supply chain, but Ryder is prepared to help customers respond to these changes by offering solutions through the full supply chain. Discover how Ryder can make you ever better at Ryder.com.